uh, different diseases can spread through the perivascular spaces. You can see here that there is a patient with neurosarcoidosis, and you can see enhancement through the perivascular spaces in the brainstem and both cerebral hemispheres. And again, this is a case of intravascular lymphoma, and you can see enhancement in perivascular spaces. This is a case of Clippers, which is an inflammatory disease of the brain that's responsive to a steroid. And again, you can see perivascular space enhancement, especially in the pons. Hippocampal sulcal remnant. This is again another don't touch lesion. And basically here you can see multiple cystic spaces in the hippocampus, suppresses on flare. And again, no enhancement. And this is a common lesion that, especially if you do high resolution imaging for epilepsy, you're going to see a lot, and doesn't have any clinical significance. Choroidal fissure cyst, again, the nomenclature for this lesion is based on the location, and it could be an arachnoid cyst, or it could be a neuroglial cyst or a neuroepithelial cyst, but because it's located in the choroidal fissure, it's called choroidal fissure cyst. This is a large one here, but again, it has all the features of a simple cyst that suppresses on flare and no enhancement. Again, doesn't have much clinical significance in most cases. Choroid plexus xanthogranuloma. Here is a nice example of it. And again, you can see a lesion in the atrium of both lateral ventricles. It's calcified. And if you look at the MR, it usually doesn't suppress on flare, and it can actually show restricted diffusion, as you can see here. And you may see some linear enhancement in the cyst walls. Sometimes when it's big like this case, it could frighten the clinicians, but as radiologists, you should be familiar with this lesion that doesn't have any clinical significance and just should be left alone. All right. Hypothalamic adhesions. These are actually bands of tissue that connects the medial hypothalamic nuclei. They can be mistaken for hamartoma, and you can see a few examples here. These bands of tissues that basically connects the medial nuclei of hypothalamus together in midline. And there have been a few publications about this entity in the past couple of years, and there is some controversy in literature. One paper was published in 2014 and indicated that they are a form first of holoprosencephaly, and they are commonly associated with midline anomalies. But then this was followed by another paper indicating that most of these patients are asymptomatic, and in the absence of any symptom, they don't have any clinical significance, and they are incidental. And this was actually consistent with our experience at Penn, that we had 36 patients, and most of the patients didn't have any clinical symptomatology and or any other anatomical abnormality. And I'll show you one example here. You can see this hypothalamic adhesion on sagittal. It really looks like a nodule and can mimic a hamartoma. But again, if you look at the axial and coronal, you can see that it is just a band of tissue connecting the medial aspect of the hypothalami. And compared to a hamartoma, which is this nodule here, and it looks like a hamartoma on sagittal and also on axial and coronal. And
Ali, can I ask you a question about that?
Sure.
So on this image, it looks like it has a slightly different signal than the brain. Is that your experience, that the hamartomas sometimes differ from the adhesions in that respect?
So hamartoma's signal intensity, I mean, at least from a textbook perspective, there's this understanding that they should exactly be similar to the gray matter, but that's not the case. And I have seen hamartomas, especially when they become a little bigger, they can be different from the signal intensity, and they can be a little bit, for example, brighter, like we see on this T2. So I guess the answer is yes. they can be different. Adhesions are always follow the signal intensity, but hamartomas, especially if they're bigger, they can be different.
Thank you. That's very interesting because it's for me an uncommon lesion. So if I were to see that signal difference, now I know not to change diagnoses.
Yeah, sure. So caudate tail, so caudate, we're all familiar with caudate, but the problem is that as most people are familiar with caudate head and caudate body, but a lot of times people can forget that the caudate nucleus actually continues posteriorly and connects to the amygdaloid body. And so the very terminal part of the tail of caudate is located above the temporal horn. And there's a lot of variations in caudate tail. And this is work that we did a few years ago at Children's Hospital of Philadelphia. And we looked at the variations in the shape of the caudate tail when it is adjacent to the temporal horn. And you can see that in some patients, it's very nodular, almost looks like a heterotopia. But in some cases, it's linear like this. And in some cases, you can't even see it. And also in terms of the location with respect to the ventricular system, sometimes it's located in brain parenchyma, sometimes it bulges into the ventricle, and sometimes it's in the interface. And so you can see that if you're not familiar with it, it can be mistaken with heterotopia. So this is a case of caudate tail, kind of nodular type, and this is a case of heterotopia. And if the gray matter is located above the in the superior aspect of the temporal horn, it's caudate tail. If it's located laterally, it's not in the expected location of the caudate tail, and it's heterotopia. And so nodularity in the hippocampus.
Can I just say, I found that paper extremely helpful because, and this to me highlights the benefit of really understanding brain anatomy, because from a management point of view, this is a day and night, and for the patient, in terms of whether you call it a normal finding or heterotopia in a patient with epilepsy. So really, I congratulate you on that work, and I found that very helpful in my own practice.
Thank you. I appreciate your kind comment. So let's move on to the nodularity of the hippocampus. So when you do high-resolution imaging, one of the cornerstones of high-resolution imaging for epilepsy imaging or for other forms of imaging is a MP-RAGE sequence. And when you look at the MP-RAGE sagittal sequence, you see some variations in the nodularity of the hippocampus. In some patients, it could be smoother, but in some patients, it's nodular or even more nodular, like this patient. And it's something that it can vary between the patients, and it can be within the normal range, although patients who have volume loss in the hippocampus and are moving in the direction of mesial temporal sclerosis, they tend to have smoother hippocampi without nodularity. So that's something to keep in mind, but within the normal population also, there is some range of variation between the nodularity that you can see. Asymmetric gyri and sulci. Again, it's important to be familiar with the normal anatomy. And here's a patient that came to CHOP a few years ago, and you can see that on the right side, this is the superior frontal gyrus. This is the central sulcus, and you can see that it's normal on the right side. However, on the left side, the central sulcus is split in half by the superior frontal gyrus, which goes way posteriorly compared to the right side. And so what's the significance of this? This patient had seizure, and the patient also underwent a magnetoencephalogram, and on MEG, we were able to localize the abnormal activity exactly to the location of the split motor cortex. Indicating that this anatomical abnormality is responsible for patient symptom. Valerian degeneration in the brain and cord. I'm sure you all are familiar with Wallerian degeneration in the corticospinal tract, and that's the most common Wallerian degeneration. And when we talk about it, that's usually what we indicate. And you can see the upper motor neuron starting in the motor cortex, coursing inferiorly through the internal capsule, cerebral peduncle, and then the decussation happens at the level of the medulla. And if you have any lesion, most commonly infarct, in the corticospinal tract, you can see the downstream effect of Wallerian degeneration. Here's a patient who had an infarct, and you can see Wallerian degeneration in left cerebral peduncle. And another patient, pediatric one, and you can see acute Wallerian degeneration, which actually in pediatric patients can be associated with restricted diffusion. And here is a chronic case of left MCA infarct, and chronic cases, you can see atrophy. And you can also look at it by DTI. There's another type of Wallerian degeneration in the pontocerebellar tract, which happens in patients who have pontine infarcts involving pontine nuclei. And you can see if you have an infarct here, the tracts that go into the cerebellar hemispheres through the middle cerebellar peduncles are disrupted. And if you follow a patient with pontine infarct after 3 months, you can see bilateral abnormal signal intensity in middle cerebellar peduncles indicative of Wallerian degeneration. So you're following this patient and you see this bilateral abnormality, and that is indicative of Wallerian degeneration. You don't need to take any action. There is not a new infarct or any demyelination or a toxic insult, although it's symmetric and bilateral. So just be familiar with this pattern. Mammillothalamic tract. So if you look at the high resolution T2 image at the level of the third ventricle, you usually see 4 dots. So the anterior dots are the fornices, the posterior dots are mammillothalamic tracts going from the anterior thalamic nuclei to mammillary bodies. And if you have an infarct or a lesion involving the anterior aspect of the thalamus, then the downstream effect would be atrophy of ipsilateral mammillary body, which you can see here. Another form of Wallerian degeneration is hypertrophic olivary degeneration, which involves the dento-rubro-olivary pathway or triangle of Gillen and Molleret. And it's in between the olivary nuclei, contralateral dentate nuclei, and ipsilateral red nuclei. Anywhere in this triangle, you have a lesion, you can have develop hypertrophic olivary degeneration. Here's a patient that you can see there is a tumor here adjacent to left cerebral peduncle and left dentate nucleus. And subsequently, after surgery, you can see that contralateral to the dentate nucleus that was injured during the surgery, you can see hypertrophic olivary degeneration. But if you follow hypertrophic olivary degeneration enough for a few years, eventually it will get back to normal. But that usually takes a few years, usually 2 to 3 years. And another interesting finding that you might see in cases of hypertrophic olivary degeneration is that on the ipsilateral side, if you look at the red nucleus with susceptibility weighted imaging, you can see decreased mineralization secondary to disruption of this pathway. You can also get Wallerian degeneration in the cord. We have the cuneate and gracile nuclei and tracts in posterior column of the cord. And here's a patient that had surgery, and you can see that there is a tumor here. But the patient underwent resection of this tumor. And this 2 weeks after surgery, you see the cavity, no signal. But when you follow the patient after 3 months, you can see that there is new signal abnormality in posterior column of the cord, and also on axial, you can see it very nicely here. And that's nothing to worry about, because you can see it's very nicely located in posterior column of the cord, and that is indicative of Wallerian degeneration in posterior column. Pituitary gland. Again, a pituitary gland is an organ that varies a lot with age, depending on the hormonal status, puberty, and also it increases in size in pregnancy. So these are things to keep in mind about pituitary gland. But also, in the context of different diseases, it varies. For example, if you have intracranial hypotension, the pituitary gland enlarges, along with other findings of intracranial hypotension, for example, sagging of the tonsil or effacement of the prepontine cistern or decreased angle of midbrain and pons. Also, patients who have chronic shunting, they tend also to get enlargement of pituitary gland, as you can see in this case. So if you see a patient with chronic shunting with pituitary gland enlargement, this is really not something to be worried about in most cases. So you don't need to recommend like a follow-up pituitary MR. In the context of chronic shunting, it can happen frequently. And also in patients who have KRA2, again, you can see enlargement of pituitary. So prominent pituitary in the context of KRA2 is expected. I'm going to talk about corpus callosum in chronic shunting. Patients who have chronic shunting, you might see a scalloping of superior aspect of the corpus callosum, and it's usually because these are the points that the veins kind of enter the corpus callosum, and you can see this appearance here. So again, this is something expected in patients with chronic shunting and nothing to worry about. There's another abnormality of corpus callosum that happens again in the setting of shunting, and those are patients who had chronic hydrocephalus for a long time and then they get shunted. And again, because of the decompression that they have suddenly, they might develop this reactive edema pattern with T2 prolongation in the corpus callosum. And again, this is something that occasionally can happen, and that's nothing to be worried about. I'm going to talk about a relatively recently described entity. It's called benign enhancing foramen magnum lesion. And the characteristic location of this lesion is located in posterior aspect of the intradural vertebral artery, just distal to the dural penetration. It is perceived to be a varix or a ganglion, but it might mimic other entities if you're not familiar with it. And here is a case. The typical imaging finding of this benign enhancing lesion of foramen magnum is T2 hyperintensity on flare. You don't really see it on T2 or diffusion, and it enhances following contrast administration. And again, you can see it on this flare. And actually, this is a case that Dr. Memorian sent to me last year. And then thank you for sending me this very nice case. And this is a case of initial MR. You can see enhancing lesion here. You don't see anything on T2. And so 2-year follow-up imaging, no change. And again, you don't see it on T2. So this is a typical case of the benign enhancing lesion of foramen magnum. So obviously in the differential or meningioma or aneurysm.
Ali, if I just say, again, this is another benefit of these awareness of these normal variants. While radiologists, we frequently ask people to come back for follow-up when we're not certain about a finding. It's no trivial thing for a patient to take time off of work, away from their family, co-pays, et cetera, for these follow-up scans. This patient had several follow-up studies. So again, if you can just put to rest a finding and say it's normal, no follow-up is needed, you've done the patient a great service.
Thank you. That's a great point. And so I'm going to talk about vascular structures, starting with developmental venous anomalies. And as you know, DVAs are extremely common, and these are basically due to lack of development of normal medullary vein in some parts of the brain, which is replaced by a medusa-like appearance of draining veins that are drain eventually into a central draining vein. And frequently they're associated with a cavernoma, as you can see here, cavernoma and CT calcified. And also you can see a big DVA here. In about 10% of cases, they can be associated with T2 prolongation. And a lot of these cases that have T2 prolongation adjacent to a DVA, they're not symptomatic. In some cases, if DVA drainage vein is severe stenotic that can be progressive and become symptomatic. And I've seen a few cases, but a lot of times these abnormal signal intensities adjacent to a DVA, they will be stable over follow-up, and they don't have clinical significance. A variant of DVA is venous predominant AVM, and that's actually a DVA that is located in the drainage territory of an AVM and looks like a DVA, but is actually an AVM. And you can see here is a patient that has an intraparenchymal hemorrhage. And when you do cerebral angiogram, you can see a DVA-like structure in the arterial phase with early draining vein. And this was a venous predominant AVM that was embolized. Here's another patient with intraventricular hemorrhage. And when you look at the CTA, again, you see a DVA-like structure in posterior aspect of left thalamus with a draining vein. And you can see it better on cerebral angio. And again, this is a venous predominant AVM that although looks like DVA, but it's not a DVA and should be treated as an AVM. The abnormalities associated with DVA are, and we can see them on physiological imaging, because DVA alters the hemodynamics and causes increased perfusion in DVA drainage territory. And they can also show metabolic abnormalities on FDG PET imaging. Here is a case of perfusion imaging. You can see a cavernoma and also a DVA in left cerebellum. And you can see that on DSC perfusion imaging. These are RCBV maps. You can see increased perfusion in the drainage territory. Another case, again, a nice DVA in right cerebellum, and these are DCE MRs, and you can see that, again, increased plasma volume and area under the curve on the DVA territory. DVAs should not show increased signal on ASL perfusion imaging, and actually, if you see increased signal in ASL perfusion imaging on DVA patients, that could be an indication of shunting, and you might be dealing with an AVM in these cases. On PET imaging, we did a study a few years ago, and we looked at the DVA and FDG PET imaging, and we saw that about 38% of these patients have abnormalities on FDG PET. Most commonly, they show hypometabolism in cerebral hemispheres. And DVAs that drain the gray matter, they're more likely to be hypometabolic compared to the ones that drain white matter. And let me just move the slide. Here is a case, and you can see that there is a DVA in right temporal lobe. And if you compare the right to left, you can see that you see decreased activity in the right temporal pole. And that's important because when we do seizure imaging, a lot of times we do high resolution MR followed by PET to decide whether the temporal lobe is the source of the seizure. And it's important to keep in mind that DVAs could be in any part of the brain. And if you see hypometabolism, that could be due to a DVA. And I'll see you other examples. Here is a DVA in left cerebellum, and you can see that it is hypometabolic. Some DVAs are isometabolic, like this DVA. It doesn't have any difference compared to the rest of the brain. And here's a patient with left temporal DVA, as you can see here. And you can see that there is decreased activity on the left compared to the right side. And this patient had an inconclusive EEG and eventually underwent surgery with a temporal lobectomy, but the seizure frequency didn't change. So sometimes it's important to be aware of this to prevent unnecessary surgery. And this is a recently published study that actually came to PubMed 4 days ago, and we looked at the patient with epilepsy that had DVA, and the epilepsy location was not predicted by the DVA location or FDG activity associated with the DVA. So even the DVAs that showed hypometabolism on FDG, they didn't predict seizure, and they did not co-localize to EEG findings. Capillary telangiectasias. These are basically lesions that you don't see them on FLAIR, and they show faint enhancement, and they show increased signal and perfusion imaging, and they are abnormally dilated capillaries with otherwise normal brain. These vascular abnormalities can also exist together. Here's a patient that you can see capillary telangiectasia in left thalamus, and also you can see a DVA here. And here's a patient that you can see a DVA and also adjacent capillary telangiectasia. So kind of these are mixed benign vascular abnormalities in the brain. And again, it's very important to recognize these capillary telangiectasias, because a lot of times we are treating a patient with a small mets with gamma knife. Here's a patient with a mets here that should be treated with a gamma knife. Here is a capillary telangiectasia in the pons that should be left alone. We don't want to treat this lesion with radiation, because this is just a capillary telangiectasia. And here's another patient. You can see a brain mets here. And you can see another faintly enhancing lesion in medial left thalamus. A little bit of susceptibility, no abnormal signal on flare. This is a capillary telangiectasia, and you can see MR from 1 year before that showed the same finding. So stable, stable. This is a met that needs to be treated. All right, so variations in the venous system. There's a lot of variations in the venous system. I'll just point a few. One is superior ophthalmic vein in intubated patients. And actually, this is something that we studied a few years ago, and it was published in AJNR. And we looked at the patients who are intubated, especially patients who are undergoing positive pressure ventilation. And we saw that there could be a significant change in diameter of superior ophthalmic vein after the patients are intubated and are undergoing positive pressure ventilation. Like this case, you can see marked enlargement of superior ophthalmic veins. And we looked at two subsets, patients with trauma and patients with intraoperative CTs who were undergoing epilepsy surgery or lead placement or other forms of intraoperative CT with positive pressure ventilation and intubation. And we saw a significant change in the volume of, in the dimensions of superior ophthalmic vein after intubation and positive pressure ventilation. Again, this is a patient with intraoperative CT, very dilated superior ophthalmic veins. After extubation, you can see that they're back to normal. So something to keep in mind, superior ophthalmic veins can change after intubation and positive pressure ventilation. So if you see a patient with trauma, obviously if the patient has multiple skull base fractures that course adjacent to the cavernous sinus, you have to think about other ominous entities such as carotid cavernous fistula, but keep in mind also that they can change in diameter secondary to intubation and positive pressure ventilation. All right, so this is a patient, again, showing that the venous plexus can change. A sagittal MR of a patient who had significantly dilated bladder. And you can see this abnormality to signal intensity and serpiginous structures posterior to the S1 vertebral body. And the patient underwent catheterization of the bladder. And this is a follow-up MR. Within 24 hours, we can see that everything is gone. So this was secondary to dilated venous plexus, mimicking epidural pathology. This is another case that, again, you see kind of burst C1 fracture. And also you can see a circumferential hyperdense structure, kind of circumferential to the thecal sac, which it could be hematoma based on imaging, but it has a circumferential pattern. But when we did the MR, you can see that there's flow void here, and also MRA showed that there is a flow-related enhancement extending into the epidural space, and the cerebral angio showed a traumatic AV fistula, which was treated. So head and neck, I think these are just my last few slides. So silicone is something that is used in retinal detachment surgery, and when you want to do vitrectomy, the surgeon will fill the vitreous cavity with silicone, and you can have the chemical shift artifact in posterior aspect of it, and on MR and on CT it's hyperdense. So silicone can kind of move through the optic nerve and even go to the brain. Here is a patient that silicone is in the left orbit, but you can see something hyperdense in the frontal horns. But the thing is that if it was hemorrhage, it should have been dependent in occipital horns. So When you connect all the imaging findings together, and you can see that this is non-dependent, hyperdense, the patient has silicon in the orbit, and you can see hyperdensity in the optic nerves, and indicates that the silicon moved in the brain, and this is not intracranial hemorrhage. Arrested development of a sphenoid sinus, this is a common entity in the skull base that should not be mistaken for a mass. You can see that the left sphenoid sinus is underdeveloped, and on T1 it's bright, on T2 it's also bright, so it's kind of like it has a fatty density, and it's common not to be mistaken for a skull base tumor. If you measure it on CT, you see negative numbers. And air, again, if you're dealing with trauma patients, if you see a little bit of air in cavernous sinus in the masticatory space, wherever there is a vein or superior ophthalmic vein, that can be a common finding. And some air can be entered the venous circulation during the IV line placement in trauma patients. So this is something that can commonly seen in the vein. If you see a vein, an air in the artery, that's not good, and it can have serious consequences. But a little bit of the air in the venous system, especially in trauma patients, that's something that frequently you see, and that's nothing to be worried about. And that was my last slide. Thank you for your attention.
Thank you very much. That was very illuminating, and I can tell you from my own practice that I have struggled with a lot of these things over the years. Those dilated superior ophthalmic veins, I am a little embarrassed to say that at one point or another, I suggested the patient may have had a carotid cavernous fistula. So again, I think awareness of these variants will help the radiologists to avoid these pitfalls, and in the end, and the main thing, it helps patients avoid needless follow-up or worse. So again, thank you very much. I really appreciate your taking that time out of your busy practice. And I couldn't help but notice how many of these cases are your research. And so I congratulate you on that success.
Thank you very much. And it was a pleasure to be here. Have a good day, everyone.